Welcome and hello to everyone to today's Spotlight Series episode. I'm Colleen Ferris, Director of Innovations and Strategic Development at Healthcare Excellence Canada, and I'm pleased to be your host today. Before we get started, I'm going to go through some of the technical components to ensure all of you joining us from across the country have what you need online for a positive experience. Please note that this session is being recorded. We are pleased to offer French simultaneous interpretation provided by Boost Events, a subsidiary of Boost Lingo LLC for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If you do not see the interpretation menu on your screen, please select the three dots, More menu, and select Interpretation. We invite you to share your questions and comments at any time during today's session in the chat box in either English or French. And we encourage all of you to respond to comments and answers as we go along. And if you need any support at any time during this webinar, you can reach out to tech support, soutien technique, using the direct chat feature. So that wraps up the technical items that have needed to be shared so we can move on to today's Spotlight series. And as we begin, I want to acknowledge and start that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, I acknowledge that I am coming to you today from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. We invite you to introduce yourself in the chat and let us know the lands you are joining from today. And thank you to the HEC team in the background who's adding the link to the Native Land website in the chat so you can also learn more about the territory you are joining from. So about our Spotlight series. This is an opportunity to have focused, constructive discussions and explore solutions to make improvements last as we work together to shape the future of quality and safe healthcare across the country. Today's episode is titled Pathways to Better Care, Expanding Access and Easing Pressures on Emergency Departments. This is an opportunity to discuss the impact of primary and integrated care can have on reducing emergency visits and the health workforce, identify strategies to expand access to primary and community care, and share examples of how these strategies have been applied that help and support the workforce and those needing and receiving care. Our panelists will share insights gathered from their work and experiences on primary and community care solutions. So at this point, I would love to ask our panelists to join me on video. And joining us today is, I will just do a quick introduction, but really allow them to introduce themselves before we get on. Angela Sereda, who's joining us, who's from Saskatchewan, who's the Senior Operations Manager, Mobile Integrated Health Program at Medavie Health Services West. And really appreciate Angela also making time to join today, recognizing the extreme pressures and the terrible situation in Saskatchewan, and even what Angela and team have had to do over the past few days in support for the efforts in Saskatchewan. So thank you very much, Angela. Erin Ballah, Director, Primary Healthcare, Chronic Disease Prevention and Management from Eastern Urban Zone at Newfoundland Labrador Health Services, and Ron Beleno, running from another event coming to us. Thank you so much, Ron, for joining us. And Ron brings the lived experience as a family caregiver advocate. So welcome, Ron, Erin, Angela. And before we jump into the conversation, and I know the four of us have had time to talk before, I'd really like to start by inviting each of you to introduce yourself and how you connect to today's topic. So I'll first ask Angela if you can come and do a brief introduction, and then we'll pass it around and then get into the discussion. Thanks, Angela.
Thank you very much, Colleen. Very honored to be here with Erin and Ron and Healthcare Excellence Canada to continue the great conversations that you carry forward across our country. My name is Angela Sereda, and I go by pronouns she, her. It's an honor to be here today on Treaty 6 territory, the traditional lands of the Cree, Saulteaux, Dene, Dakota, Lakota, and Nakota peoples, and the homeland of the Métis Nation. I am the Senior Manager for Mobile Integrated Health for Medavie Health Services West. And I've been in EMS for over 32 years, and I'm an advanced care and community paramedic. Working frontline as a community paramedic and being in the role of developing innovative models of care. I believe in meeting people where they're at that moment and really empowering them to be able to make the choice of where and how they choose to receive care. So that is my connection to today. So I will pass it on to Erin.
Yes, as well as Angela, very honored to be here. I am a physiotherapist by trade. I have been working now in the primary healthcare space for over the past 5 years and have been a longtime ally of Healthcare Excellence Canada across many different quality improvement programs. The reason that I'm connected to this work is through the care that we provide for longitudinal as well as episodic primary health care within the urban area of Newfoundland and Labrador. So we are embarking on many different initiatives, some in partnership with Healthcare Excellence Canada that allow us to increase access as well as equity and access for primary health care for all populations, particularly focused on the vulnerable and marginalized individuals. So thank you so much for the invitation.
Thanks so much, Erin and Ron. Not sure if we're having some connection issues with Ron and that, so we'll just give it a moment, but recognizing in the world we live in that quite possibly could be the case. I believe Ron has gotten disconnected, so we'll work to get Ron back online. So Ron, for those that haven't had the opportunity to meet Ron, can hear more about him. But maybe as we look to get him back on, maybe Angela and Erin, as Ron's, as he said, he's going to try and get back on. Just what is the most, recognizing where we are? We know that a lot of folks, when we're thinking of access to care and why maybe people say, why highlight the emergency departments? I think it's certainly the emergency departments. We're not saying don't go there. They serve their purpose, but we also know folks are going there because they cannot receive care elsewhere. And we know there's such incredible solutions that are happening in a lot of different ways across this country to really improve that access to care. And HEC has even come out and talked about a care forward movement, which we'll highlight a bit later in more detail later on. And but when you hear about moving care forward in the sense of primary care and community care, what does that mean resonate to you?
I'll start with that. I think access to care is, it's a paradigm shift that we need to make in the delivery of healthcare today. And I think it's, not expecting individuals to come to us for care, that we really need to meet people where they're at within the community. And I think with that, it really shows that greater collaboration between all healthcare disciplines in the community. There's a lot of great work that's being done within our communities and within our multidisciplinary teams. And it's really about coming together and really keeping that patient client in the center and really accessing so they have easier access to care. and more of that prevention model piece.
Certainly echo the sentiments that Angela has brought forward. When I think about Care Forward and this next step now for Healthcare Excellence Canada, I really take two lenses, kind of globally. What are the next steps for healthcare? What direction are we moving in? What is the progressive path forward that may look differently than the care and how it's delivered right now, as Angela referenced, with reducing barriers and bringing care out into the community? So we have used a number of different strategies to really reduce those barriers, as I referenced, and we've been using emergency department data to help us move in different directions to understand why patients with low acuity are accessing these services, using that data around hours of operation, type of care that's being delivered, and then repurposing that or delivering that in a different context outside of emergency rooms. We've also been looking to the evidence around how we would use evidence-based models to, particularly around social work intervention, understanding why people are inappropriately using emergency departments and wrapping care plans around them so they know what services to connect with, to link with in those circumstances. I know there's incredible work that's been done with paramedics delivering palliative care and other healthcare providers that certainly allow us to reduce unnecessary utilization of emergency departments. We have examples in Newfoundland and Labrador now that are just launching around mobile primary healthcare clinics, new creations of models of urgent care delivery, and also virtual care integration to some of the primary care clinics that we have that operate within the health authority of NL Health Services. And I see here that Ron's been able to join us, so I'll hand it back over to you, Colleen.
Yes, thank you so much, Erin. And we're going to get into more of what Erin and Angela have shared as we talk about these solutions. Ron, so glad we could get reconnected. Gotta love technology. Recognizing, though, technology is a great driver about improving access to care and that. But Ron, if would love if you could take a bit of time just to introduce yourself and where
Sure.
Erin and Angela and I had just started was really about in this notion of improving that access to move care forward. We know a lot of great care is already happening, and that together we can really move that forward. So over to you, Ron.
Thanks, Colleen, and it's a pleasure to be here with Angela and Erin. So greetings, everyone. I could go straight into the conversation with an introduction, but I will introduce myself. I'm here usually wearing the lived experience voice. So as a past caregiver to a father that had Alzheimer's and dementia, caring for an aging parent, plus uncles, aunts, neighbors, friends in my world. I'm a person that loves to kind of have boots on the ground and understand what's happening in the community. Just like today, I'm actually here at Lake Ridge Health Hospital. I just did a presentation before this on technology and innovation and caregiving. Technology, I'm crossing my fingers with this here so that it works. On my end, so I'm loving where HEC is at. I've been a advisor, mentor, and coach with Healthcare Excellence Canada in the past and continue. But on this topic, to help people even stay at home, age in place, or have less visits back in the emergency room. Okay. Yesterday, I had lunch with a doctor, an emergency room doctor in Paris, Ontario, just talking about it. And last week, I presented with an emergency room doctor on essential digital health at a conference. And one of the things for me is exactly, I think, what I heard Erin say. It's kind of like back in the community. This community piece of caring within the community isn't just on the family. Okay, this isn't just the individuals. This is a community piece, and it's also not just healthcare, in my opinion. Okay, I love the Angelas and Erins of the world, but we have to bring in the community as well. And there's a lot of creative ways we're doing it. And I'm just going to plug HEC here, Healthcare Excellence Canada, is to help scale it up and speed it up. That's what I'm interested in, is that we have a lot of great stuff, as you said, Colleen, but we need to actually execute better and get more buy-in faster, in my opinion. So that's what I'll be pushing for today in our conversation.
Wonderful. Thanks so much, Ron. And I was fortunate to hear that conversation and about essential digital health last week and get to work alongside you in some of the previous work there. I think even as we've seen in the chat about the real change doesn't always begin at the top, right? And I think as we're thinking of how do we move care forward, Ron, I love that notion of like, we've also need some speed here too. The system needs it. And so a lot of this is about change and maybe how we need to think and work differently with community, patients, those that are seeking the care at the core, at the center. So when we say need to work differently, recognizing we need to work with the patients, the community, families, the workforce, and when I say workforce, the broad sense of the workforce, what does that look like for both the people who are working in the system and the people accessing the care? And where have you seen that?
I think what we need to really start to do is we have to be flexible in our approach, and it isn't just a one size fits all model. When we're looking at patients, everyone has a very unique story and a unique journey. That they're currently in healthcare. And I think we have to look at that individually and not have processes and creating our own barriers within the system of that we have to do it a certain way. And we really have to have that unique approach and be able to be flexible and have our frontline staff being flexible to address the needs that are presenting at that moment with that client or patient in the community. As well as, like Ron said, bringing in the family as they are the ones that know that client patient the best, and really having everyone involved in that treatment plan moving forward, I think is really the best place to start. It can't be from the top. It has to be from the frontline workers to really initiate some of that change and have that flexibility.
Yeah, I'll jump in there, Angela. Always insightful words. But when I think about working differently, I really consider the realistic situation that we're in from a health human resource perspective, and how do we operate in those environments when everyone is really challenged to have the clinicians that are required. And so I think we really need to focus on working smarter, not harder, working differently together, understanding care across the continuum and integrating that as best as possible. We've absolutely seen an over medicalization of treatment. I think we have right now social workers in our environments doing work that once upon a time a loved one would have been able to support their friend or family with that level of care, but in absence of somebody close to that client, that we're seeing the clinicians are having to do that work. And so we've really been focused on integrating peer supporters into a number of our different care teams, and that has been an outstanding success. We have also been re-engaging with community agencies because they play such an enormous part in the holistic interventions that are provided that support individuals. And then also those who deliver care that are largely seen outside of our health authorities. I come from an inside one, so it's often very easy to see us as a silo and forget about the private physiotherapy clinics, or even our private community family physicians who do such a large proportion of this work, but don't always have direct ties back to the health authority. So leaning into their ability to support us, identify problems, solve them together. And then lastly, when I think about doing things differently, I really think about that value proposition. Really, I do believe that we should be focused on what is value add to the patient, and using that really simplistic calculation definition of the patient reported outcomes over cost. Because if we are going to continue to meet the rising expectations and demands of our complex populations at this point in time, I think we need to be really certain that the care that we are delivering is of high value value, it is meeting the needs of the folks on the ground who are facing these challenges in access, and restructuring the way that we deliver care based on what those needs truly are.
That's a perfect segue, Ron. I need to get you in here. And as we talk about even some of the pieces that Erin and Angela have shared there, even the patient outcomes, and how are those outcomes even considered in working with patients and families? Over to you, Ron.
Super. So, Erin, you could have been in my talk like in the past hour, because even though it was on technology, I was talking about the values of the family, the patients, okay? That what is important to them and how do we rethink this, okay? It's not simply that we have to heal and fix someone with their health. It's what does that do in their lives is what I would say. Okay, what are the values? I'm not going to type it in here, but people, it's really not in the healthcare space, but I talked about psychographics. Just take a look at what psychographics means, okay, which is, someone's opinions, beliefs, values, okay, for them to act, to move things forward. So that's just something on the patient side. Their experience is huge. I always tell people, ask someone's feelings, if you can get to that question, and reverse engineer back as to how they got that. So how did you feel going to the emergency room? How did you feel when you left? How do you feel now? And if they say, I feel like I think I need to go back again soon, that didn't go well, in my opinion, right? So I always try to bring up that feeling question that some people don't want to bring up. So that's part of the patient experience is kind of my quick answer. But to also address what Angela said, flexibility and how we rethink this. Patients, many times we look at the healthcare space and say, why do they do it that way? Or why are they not being flexible? Okay? And I agree with Angela, it's frontline. Okay, frontline is the one that really is the ones we connect with. But I'm not speaking to those that are relations. Okay? Those that are in your offices, as much as I love and respect you all, I'm saying be willing to listen to your staff, to your frontline team. Okay, we can drop people off here, I think. Yeah, but so that's one thing that I'm going to suggest is that we need to also be willing to take better calculated risk moving forward. It was always defaulted to safety first, but we need to move a little faster and take those calculated risk teams with others. Colleen, I wanted to add a couple of programs out there that I'm familiar with. So for example, when it comes to social workers, I'm a huge fan of the working community, and they're getting involved in primary care. So some of the work, Peter Sheffield and Dr. Ashcroft from U of T and the Canadian Association of Social Workers. They have a new training program on how to work with social workers in primary care more. Okay, so that's a big deal. That how do we get everyone doing their role plus something maybe a little bit different? So community paramedicine is another one that I'll leave for now, but just the role of paramedics. Okay, so everyone has to look at their roles a little differently, in my opinion.
Think absolutely, certainly, and I think that's where we know there's different pathways, right, that can go about improving that access from what we've chatted about from the disease. We can talk about disease prevention, health promotion, to that team-based primary care, integration of care of services, because we know certainly those can also be very vulnerable times, as well as that workforce piece, Ron. And when say workforce, really think of it so broad, and it includes really everyone in it. And what are some of the changes that can happen within the workforce? I know, and I think as we think of working differently and recognizing some of these matters, and Erin, I think you alluded it to a bit, is we know the connection between health and social as well, right? And how even I know Angela in some of our other conversations we've talked about the role about social prescribing, and what does that mean to you, and where have you seen that as it relates with you and your colleagues or elsewhere in the system?
Well, for social prescribing, it's definitely a role that community paramedics really play kind of a pivotal moment for, because we're often the first people that come in contact with individuals. And so we really have a unique opportunity to listen to their story. And it's more about just health. It is about that social piece. It is about all their other elements within their holistic approach and how they're living. And so, how can we really connect them to those community supports and to those community outliers that, you know, we work closely with, really to help kind of evolve and really work with them from that holistic perspective. So for us, we have been able to connect individuals to, you know, whether that's sponsors through AA or NA supports. It is grief counseling. If somebody is connecting with us through mental health and loneliness, you know, we've been able to connect some of our clients with substance use when they have a passion for art, to really start to be able to reflect, and put their feelings and their journey on through art. And so it's really been quite instrumental for us and very meaningful work. So when we tie it back to even the meaningful work of the caregiver, it's really important for us to be able to go home at the end of the day, to know that we've started to make that difference in somebody and to connect them further to more than just that health supports that they're needing.
I think that notion of that, making that difference is certainly a reason why folks are often called to work in the many roles that make up the workforce. And recognizing, though it's even broader, family and caregivers step into a critical role as well. And knowing that there is so many services there, but how do we connect all of them? I know, Ron, and we also know some of that way of connection can be enabled by digital tools and support to improve access and services. Any thoughts and things you've seen in action?
So I'll respond, Colleen. I'm going to take my video off because I think I might be choppy. So let's give this a try here.
Sounds good.
For me, as someone who is supportive of technology and care, there's a lot of tools. Okay, so I'll replace the word tools that are out there. Of course, we're already using one for right now, video tool, for example. I'd like to say, what do those tools do? Okay, so something as, as Angela was saying, areas like music, art, okay, how do we get that into the hands, at least into people's homes? Okay, something as a smart home device that you can play any music you want, whatever genre you're into. If you're country music, we can get you country music. Okay, if you're into other kind of music, whatever that is. But for me, it's about the ability to make sure that with technology, how do we deliver, okay, the pleasures of life, the joys of life that people would appreciate, okay? So that's one. But then the other piece is simply how do we deal with social isolation, loneliness, that kind of stuff. Of course, we can have ways of communicating, better ways of communicating. One of the ways we're kind of getting into some interesting places, AI, okay, artificial intelligence. Okay. People are having conversations with AI tools now. I'm not sure, I think I'm throwing that out now to this group. I'm still trying to figure out where I sit on that. There are some innovators out there that has AI tools in different languages, okay, in different languages, in someone's maybe natural language. They could have a conversation. Okay, and it could be just basic stuff to collect health data. Say, how are you doing today? On, okay, and what's your plans? Okay, and we're going to have someone follow up with you if you need some more something else. Okay, that alone could be that way to connect someone to the community, even though they'll listen. So that's what I'm going to throw out there at this moment, Colleen. Yeah.
Thanks so much, Ron. I think still, unfortunately, some choppiness with the sound, but I think the team's going to connect with you to hopefully find a bit of a solution there, because to make sure we're all hearing all your great thoughts and actions you've seen, that and items that, reminders for us or directions that we need to consider about how do we improve access as well. I think, you know, I'd love, Erin, if maybe you could tell us a bit more. You mentioned how you've also looked across the system, looking at the evidence. What what do we maybe need to do, and can we try and do things, recognizing even across Newfoundland, Labrador, there's a lot of different needs, each community being unique. But you talked a bit about that integrated peer support. Wondering if you can share a bit more about that experience and that. Thanks.
Sure, Colleen. So we had a recognition that there was a clear gap for folks that, seemingly they were interested in taking a step, whether that be towards a path of recovery, or whether that be something as simple as, a journey to have a better appreciation and management of chronic pain. And so while we don't have that expertise within NL Health Services, we engaged a community agency who specializes in this level of work. And so they are hiring individuals that have lived experience of a variety of different histories and pasts. And then we've been able to work alongside peer supporters to help people along various journeys. So in our experience, we've particularly used this most successfully with supporting vulnerable populations, particularly those with a history of substance use disorder. And we do have peer supporters that are engaged in our healthcare teams that deliver primary care at our transitional living spaces. And then we also have peer supporters that are going to different community agencies, as well as supporting those who may be sleeping rough, and accompanying our nurse practitioners and social workers, addictions counselors. We have peer supporters that meet people where they are. We reduce as many barriers as possible, and it could be something as simple as working with a client to travel to an appointment that may have been particularly trauma invoking to attend in the past. It may be to help them complete forms, to be able to access federal funding for housing options. So we've used peer support really in partnership with the community agency to see it to be fully successful. It's always a work in progress, and the unbelievable experience, and then the reality that those with lived experience bring to our decision-making tables. It's just an opportunity for us to bring that generally historic quiet voice up to the forefront, and it eliminates that again, kind of historic pull to have paternalistic decisions made for folks who are accessing care. So it's been a real eye-opener and extremely successful in the Newfoundland and Labrador environment.
Really great. Thank you for sharing a bit more, Erin, and some good points there, especially Ron's getting reconnected on different sounds. So we're going to wait to I wanted to kind of from there maybe go into recognizing as we think of inequities in the system. But maybe before that, just Angela, you mentioned about absolutely meeting folks where they're at, the communities where they're at, that needing to be flexible. And I think we say that, but how have you seen that show up across the services you and the team provide?
Yeah, so it can be as simple as getting a referral into our primary healthcare system for an IV antibiotic, and when these people are discharged from hospital, they're given a phone number to call to go to the treatment center. Well, many of our clients that we deal with, one, don't have a phone. Two, it may be out of reach in order to access that care because they do not have transportation options. But the other piece that we're also finding is those that are living on the streets also have all their belongings with them, whether that's on a cart, or other items, and then for them to go into a facility where do they put their belongings? Because quite often when they come out, they've been stolen. And so we really have to really look at healthcare differently to be able to say, where can we meet you? Everyone should have the choice on where and how they receive care. And I think it's really important to really, again, we keep on saying, meeting people where they're at, but it is really important because we want to make sure that we're not putting up some of the barriers to that health piece, and that we can really make a difference in somebody.
Yeah, I think that is such one of probably countless of why we need to think and do things differently, right? And not to make barriers even more than already. And how do we break down some of those barriers, right? To really, we know many folks experience inequities in the system. And so how through, and Angela, even what you've shared there, um, demonstrating how can we look to making sure that when we're thinking of improving access, it doesn't come with more inequities as well. I know the team's gonna work to get Ron unmuted. We'll maybe do a check, Ron. Are you able to unmute? If not, might go to Erin, and then just a bit of a conversation amongst the three of you on that. And I see a few questions in the chat I want to try and get to as well. If not, Ron, I think still trying to unmute. So maybe Erin, over to you. Oh, go again, Ron. Sorry. Erin, how about we go over to you while we work to get Ron connected there?
No problem. So yes, absolutely. I think the way that we reduce inequities is to ask the folks who are experiencing them, like, what are you seeing as the barriers? And while sometimes there is an inherent power differential in a clinician and an individual who's experiencing inequities throughout, their intersects with the healthcare system, we take different avenues, such as working with community agencies who often have deep experience of working with those who have faced these inequities. And the other is lived experience councils. So we're so fortunate to work with community agencies that have really tried to find a voice for those that are often unheard. And some specific examples of how we have been able to deliver care differently for those who are rather marginalized in our societies. Number one, we're actually designing a clinic right now to be deeply embedded within our downtown core, Angela, and there are lockers available. So something that we wouldn't even normally see through our traditional primary care clinics. Now we're thinking about what are those barriers that often present and why people would not want to access care in that way. We have in-reach services. We go to the community agencies where someone has a trusted housing case manager, and then we deliver primary care service or navigation supports to get them the care that they require. We have 2 mobile units, and that is health and housing outreach that's delivered again in combination with a community agency and Homelessness St. John's within our community. We have walk-in clinics that are really dedicated for those who are marginalized, no signs, very discreet, because we don't want those clinics to be overpopulated with folks who don't experience those barriers. And so we are very targeted about how we support those who've been marginalized, and even more around the palliative care service development for those who are marginalized. And we've been doing that in partnership actually with Healthcare Excellence Canada through one of their, the quality improvement initiatives to increase equity and access to palliative care. So really thinking differently about how do we eliminate those barriers and lifting up the voice of lived experience. So we co-design service as opposed to making those paternalistic decisions on how care should be received.
So much, Erin. Ron, we're going to check in on sound.
Can you hear me?
I can hear, but
No?
bit muffled, but let's try it.
Hello? I'm so deep in the hospital.
I think that's a bit better.
No? Okay. Sarah, can you repeat the question for me?
Yes, we're just talking about how, as we're thinking of ways of improving access and care, how we know there's already inequities in the system. And as we work to make improvements in the system, the goal is to remove those inequities, decrease the barriers, all of that. How do we also, as we're moving to improve, looking to improve access, really making sure that those that have experienced get better access, but and also making sure not creating more inequities within the system. And certainly Erin talked a lot about co-design, working with communities, same with Angela.
So if you can hear me okay, hopefully you can hear me better now. Colleen?
It,
Yes?
it comes and
No?
goes.
Otherwise,
yeah.
Okay. Okay. I'm gonna leave the hospital and answer this. If you let me, yeah, let's figure that out. Okay.
So Ron's going to be on the move in order to maybe get outside and maybe some better connection, so we can hear Ron's thoughts from that point. And one thing, just seen some questions in the chat there. And also I'll highlight, there's a lot of some promising practices of programs that even like Erin and Angela and Ron have highlighted, of work that teams across the country have done to improve access. To check out some of those on the Healthcare Excellence Canada website. But recognizing some folks are going to the emergency rooms for, we've talked about different items, such even social isolation, but there might be other health matters that don't need, as we've highlighted, don't need an emergency department. And such as, let's say, bladder infections, just highlighting one of those. Have you seen, or how within some of the programs within your work you've seen active decrease of folks going for some of those reasons that are sometimes not the reason you need emergency services? And whoever wants to start, Erin or Angela, yeah.
Sure. Yeah, I think I alluded to some of the different strategies that we've tried in the urban setting of Newfoundland and Labrador. And one has been looking to the evidence. And actually, I would say Quebec does an incredible implementation of this model, but through case management of social workers to really understand why folks are inappropriately utilizing emergency departments. Is it that they don't have access to primary health care? Is it that they have untreated anxiety that leads them to make the decision to go to emergency, despite the fact that the needs could be better met elsewhere? So that's one way that we have tried to take learnings from the evidence that already exists and is published in the province of Quebec. We have implemented mobile primary healthcare clinics, and we have been really targeted about seeking populations that have low attachment rates to longitudinal primary care physicians and nurse practitioners. And that has been very successful. We are now provincially undergoing a redesign of our urgent care services, looking at various institutions, understanding the data as to who is seeking service, what times are they seeking service. For instance, probably no surprise to those who might have young children, we see our children hospital emergency departments flood from 4 p.m. to 8 p.m. because they're not able to access their longitudinal primary care physician or NP And so where do they go? But the emergency department, can we structure services differently that would allow us to create increased after hours access, really focus on the needs, and then communicate that well to those who are utilizing the emergency medicine unnecessarily. And then lastly, we've really looked to virtual care integration to help overcome some of those health human resource challenges that we face, and using the math, using the data to be able to say we need X number of episodic care appointments or same day appointments that would meet the needs of those that are attached to physicians or nurse practitioners in specific clinics. So using a number of different strategies, really, Colleen, to think about how we could meet the needs of the public to avoid unnecessary utilization of Emerge.
Thanks so much, Erin. Certainly comes back to some of that theme, right, of flexibility and not doing. So Angela, over to you, then we'll look to bring Ron on to kind of put a nice maybe wrap on some of these items, as it's hard to believe we're already nearing close to the end of our time together.
So I come from, then the 911 paramedic and now the non-emergent community paramedic lens, where we've really kind of focused and developed teams that have different specifics that they look into. And again, it is that adaptability, like Erin talked about, of when are people accessing services and really tailoring that. So a lot of our CP programs that we have work not the traditional hours, so that we're not duplicating services. And so, for example, one of our teams who supports withdrawal management and substance use disorder clients, they work 11 a.m. to 11 p.m. so that they have access to services in the evening. We have another team that works 9 a.m. to 9 p.m. and another team that works noon to midnight. So really looking at the needs and looking at each community individualized, right? Because there's different resources and pressure points in each community that are very different. The other piece that we also really started to tackle is who we call our friendly faces that are accessing the 911 system quite regularly. So now when we have these individuals accessing care through the 911 system, we'll actually refer them into our community paramedic program. And then we will actually meet them in the community to really listen more and trying to find out why they're activating the 911 system or why they feel like they're needing to. And is there any underlying supports that we can provide and connect them with that maybe that they're missing in their kind of journey that they're on. So we're really kind of looking at, a few different pieces, as well as also supportive discharge support for the emergency department, where physicians can connect patients to the community paramedics to really provide some follow-up assessments in the community so that everyone feels more comfortable instead of having them, staying there longer than they maybe need to.
So great, and it really shows that it's not just a one size fits all, as mentioned earlier, right? It's everyone has their unique needs, and how do we meet them while also making sure that they feel safe to access the care. Ron, we're going to try and come to you. I think you're connected. So let me know if you're able to unmute. We'll see. I'll just have the team in the background. I know. Got the. All right.
Oh, can you hear me now?
Yes, we can hear you. Wonderful.
Okay.
Ron.
Apologies
So
for the guy that's the tech guy. It's hasn't worked out today, but hi everyone. So I'm just going to share my thoughts as I was scrambling here. At the end of the day, we've said it earlier, both Erin and Angela, but we need to change how we're doing things. Okay. For me, change, specifically for the patients, it's like we need to execute differently and think differently. One of the spaces I want to talk about is even just the narrative of how we do this, the stories of how we tell everyone, okay, how do we take care of each other so that we don't just go back into the emergency room? This is not all just about healthcare. at this stage anymore. This is about life care. This is something that was spoken about through SE Health. SE Health last week, they were talking about not just the healthcare model, but the life care model. So I am kind of pushing that we need to bring in that conversation, that all this work that everyone needs to reshift and how they do things, okay, is to support people in their lives as they kind of maybe go back home from the hospital, and we support them in so many other ways that might not necessarily just be something that is obvious from the health side. Okay, when you think of creative arts therapies, okay, as Angela kind of snuck in there earlier, I do a lot of work with that. That creative arts, you might not think is healthcare specific, but it is. Okay, so that's what I'm kind of throwing out to people. That how do we bring in all these things, that these stories, these narratives, okay, that is supposed to support you in your health so that you don't go back to the hospital, okay, or to the emergency room. We need that. But at the same time, we need people from the healthcare side, not necessarily the frontline staff. I'm looking at the leaders, okay, and I'm challenging them to say, hey, you got to be much more better at what you do and reshift it. If you're the barrier and everyone else is saying something else from your frontline staff, then we got to get rid of you. I'm going to say that with a lot of love. Okay. So that's kind of what I'm saying is we got to execute better, and the leadership needs to do so much better. Or the next generation of leaders, the Erins and the Angelas here, they're there. They're the leaders there. But we need to create many more leaders that have these same values. So that's kind of what I'm going to jump over.
And I think just to add to that, Ron, I think it's recognizing what worked yesterday isn't going to work today, and what we're doing today, we're going to have to shift again in the future. And so that is the evolution of healthcare, and we really have to be limber enough to be able and to self-reflect and recognize that as leaders within healthcare, to be able to shift consistently.
Colleen, I'm going to just go one phrase, one last thing here. Is that I've always been a fan of improvisation. And the rule of improv is you always say yes and. Okay. Whatever comes to you, say yes. Doesn't mean it's going to happen. Okay. But exactly what Andrew was saying is that ability to say whatever you say yes and let's keep going until we hit a barrier. Right. But there's a lot of saying no, no, no. That's not, I think, the path that we need to go. Everybody moving forward as is. Yeah.
I think that's a great, the yes and how do we keep on moving forward? It almost brings us back to that care forward piece. Just cognizant of time. Ron, Angela, Erin, I'm going to give you a moment to think of, if you had 30 seconds of what you would say to those online. And as you're thinking of what that's going to be, I just would, I'm going to turn to the HEC team in the background and also highlight that HEC wants to support teams that are looking of ways to improve access to care that can ease pressures on emergency departments. We have a series of program offerings that come with seed funding, coaching, currently open online. So I will turn to the team to make sure they put those links into the chat, and we will certainly share those post-webinar. But in case you joining us are interested of continuing great work you're doing or wanting to do new ways to improve access, please consider those potential opportunities to support you. So back over Erin, Angela, and Ron, and I'll go Ron first. As we've got connection, I want to make sure we've got
Yeah.
you. Your 30-second final pitch you wanted for all of us here to take away, then Angela and Erin.
Yeah. So I'm going to say first and foremost that we all here are cheering for each other, right? We want everyone to succeed. I think that's an approach. And again, what's that narrative? So when I hear patients and have issues with, healthcare, I'm saying, no, we want them to succeed. Okay, but we need the leaders. So I am calling upon anyone here to push leadership, or if you are a leader, don't be afraid to raise your voice and move it forward, for the better. Okay, so speak up and let's keep changing that story moving forward.
Wonderful. Over to you, Angela.
So, I agree with Ron. I think it's really everyone is on an individualized journey. And I think we really, everyone offers, uniqueness to what they're needing. And I think as healthcare providers, it's up to us to be able to really just take that time and build that relationship. But I want to highlight something I saw in the chat because it is probably one of the best things I heard, and I'm sorry I'm going to get their name wrong. Brennan Santos put in the chat. There is no innovation without inclusion, and there's no excellence without empathy. And I think that's probably one of the best things that I have heard in my 30 years of healthcare. So I want to do a shout out to them for that. Thank you.
Wow, it's hard to follow that, Angela. But what I would say is that this is hard work, that primary care, community care transformation is difficult. And I won't be the toxically positive leader to say that it's all roses and unicorns and rainbows. But what I can say is that while there may have been the three of us participating in this call today in the Spotlight series, there is incredible work happening all across the country that you can see in the chat. Everyone is sharing these positive news stories of barriers that they've been able to overcome, whether that be individual for a patient or those systemic barriers that often prevent us from innovating and doing the good work faster. And I'm going to leave you with a quote that I wish I had said, but it was actually our past premier, Dr. Andrew Fury, who's also an orthopedic surgeon. He gave some introductory remarks at an innovation summit that we had recently, and he said, "We have a social license to disrupt the status quo and transform healthcare delivery, that we can't keep doing it the way that we've been doing it." And I think that that phrase, the social license to be better, to be different, is really freeing in a way for those who have been in healthcare and have traditionally done work the same way for decades. And so now it challenges us as leaders, as frontline staff, as patients, as their own advocates to work differently together, to achieve outcomes that we didn't think were possible. And us as leaders are really here to support our people through the change, because it will not stay stagnant. It will not be the status quo. It behooves us to support those folks to be able to execute these changes and meet the needs of our patients.
Wow, how to powerful and impactful. Thank you, Erin, Angela, and Ron. I love that notion of the social license, that empathy, inclusion. One thing we sometimes say here is this work is hard work and heart work, and I think that is needed as we think about improving access towards thinking of that life care piece. So a big thank you, Erin, Angela, and Ron, for making time for us to share your wisdom, your experience with all of us. To the audience who has connected from across the country, what you've shared in the chat about some of the work you are doing, the questions. Thank you for taking the time. We do have a short poll because feedback is important to us, so that as we continue to build these Spotlight series episodes, that we can really make sure we're meeting the needs of those that value this time and these learnings. So the team is going to pop up a poll. And again, if at any point you're interested to please join Healthcare Excellence Canada's email list and get access to resources as they come out, learn about different learning opportunities, and more that will get sent straight to your inbox. And thank you to the team in the background that's been supporting again. And once again, big thank you to Ron, Angela, and Erin for the reflections and wisdom today. And if you complete the poll, this concludes today's event, and we wish everyone a great rest of your day. Thank you.